welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EMED-PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
Today, we have Markus Melbardis, who is a PGY1 emergency medicine resident at St. Luke's Health System out in Idaho. Today, he will be presenting a journal club on cephalosporins for outpatient pyelonephritis in the emergency department, the COPY ED study. Thank you.
So a little bit of background. Cephalosporins, we know, can yield high urinary concentrations, but there is a lot of controversy out there on whether the kinetics and pharmacodynamics of cephalosporins result in a good drug concentration in kidney tissue specifically. Also, some cephalosporins do have poor bioavailability, specifically like cephalosporin or acceptanir has been talked about a lot recently in terms of its bioavailability. However, there are no real kinetic studies out there currently evaluating its renal tissue concentrations. Some more background, there's not a lot of multi-center data, including complicated pyelonephritis. Current IDSA guidelines do recommend fluoroquinolones or trimethoprim, sulfamethoxazole, or just Bactrim moving forward as empiric treatment for pyelonephritis. These IDSA guidelines did come out in 2010, so they are a bit more dated now. There's been a lot of more evidence that's come out since then to further support the use of cephalosporins in this patient population. IDSA also recommends using these two first-line agents if E. coli resistance rates are low and less than 10%. And depending on your local antibiogram and trends in resistance patterns, a lot of institutions will see that their resistance rates are much greater than 10%. Some previous literature that's been done, Foss and colleagues and Volger and colleagues both looked at uncomplicated pyelonephritis patients similar to this study here, and they found either no difference in treatment failure rates or that Volger and colleagues found that cephalosporins did have a significantly lower failure rate as compared to fluoroquinolones and Bactrim being statistically significant. There was a large VA study done by Ravelsky and colleagues. They looked at also uncomplicated pyelonephritis, and in contrast, they did find that beta-lactams had a higher rate of failure or hospitalizations relative to ciprofloxacin and Bactrim. However, it is important to note that in this study, they do call out uncomplicated pyelonephritis. However, 75% of the patients in this study were male. Current guidelines do say that male patients are considered complicated pyelonephritis. This study, the design was a multi-center, so they looked at 10 geologically diverse emergency departments in the U.S. This was a retrospective observational cohort study, and they conducted this study and enrolled patients from January of 2021 through August of 2023. For inclusion criteria, patients had to be greater than 18 years or older and diagnosed with either uncomplicated or complicated pyelonephritis and discharged from the emergency department on PO oral antibiotics. Exclusion criteria included pregnancy, bacterial prostatitis, other bacterial infections, if they had a urinary tract surgery in the past 7 days, and also if patients had multiple ED visits during the same study period, only the first visit was included in the study. I think it's important to go over the definitions used in this study as it applies to the generalizability of the study as well. So they defined pyelonephritis as patients having urinary symptoms and either fever, chills, flank pain, or CVA tenderness. Complicated pyelonephritis was defined as patients being male, having pre-existing anatomical conditions, or immunocompromising conditions. Anatomical conditions included urinary obstruction, neurogenic bladder, history of kidney stones, or moderate to severe renal insufficiency. And immunocompromising conditions included active cancer if they were on current immunosuppressive therapy. If patients did not meet criteria for complicated pyelonephritis, they were considered to have uncomplicated pyelonephritis. In order to have a positive urine culture, the specimen needed to have greater than 100,000 colony-forming units of bacteria and needed to have less than 2 microorganisms isolated. They also called out several bacteria as contaminants. And for breakpoints, not every institution specifically reported on susceptibilities for specific cephalosporins. So all the sites in this study used the CLSI recommended cefazolin breakpoint of less than 16 to define resistance. And that was applied across all cephalosporins in the study. The primary outcome they looked at was a rate of outpatient treatment failure at 14 days. And this was a composite of patients getting a new receipt of antimicrobial prescriptions for UTI. That was either based on worsening symptoms, adverse drug reactions, or an identified resistance on the urine culture and susceptibilities. Or at 14 days, they had a recurrence of symptoms, or represented to the emergency department, urgent care, or were admitted to the hospital with the primary diagnosis of a UTI. Secondary outcomes included a comparison of treatment failures. So they did some subgroup analyses, specifically looking at the different generations of cephalosporins as compared to fluoroquinolones and Bactrim. They also evaluated the rate of appropriate empiric antimicrobial treatment based on susceptibilities and the rates of treatment failures based on the duration of treatment prescribed. If you're looking at the statistics, they used means and standard deviations to determine if for each oral antibiotic prescribed. C-tests for proportions were used to determine differences in proportions of primary and secondary outcomes. Logistic regression models were used to assess associations between antibiotics received and outcomes. To enroll patients in this retrospective study, they utilized ICD-10 codes for pyelonephritis to initially draw in over 2,000 patients. Then following exclusion criteria, they included 909 patients, with 647 having received a cephalosporin at discharge and 204 receiving either fluoroquinolone or Bactrim at discharge. Getting into the results of baseline characteristics, the median age was around 36, 33 for both groups. The majority of patients were female in both groups. Uncomplicated pyelonephritis made up about 26% of both patient groups, and common symptoms for pyelonephritis included flank pain. Urinary tract abnormalities were similar between groups. None of these reached statistical significance. However, there were a few more in the fluoroquinolone and Bactrim group. History of multi-drug resistant organisms were similar between groups, but IV antibiotics at discharge were, again, not statistically significant, but numerically there were quite a few more in the cephalosporin group, which does support the current IDSA guidelines to recommend if you are going to use a cephalosporin, they recommend giving a one-time IV antibiotic upon discharge. Now, I do think it was interesting they were able to break down the administration of IV antibiotics per site. And you can see that the majority of these centers had roughly 50% of IV administration, the majority of patients in the study actually being enrolled from Miami, Florida, and they had an 88.5% use of IV antibiotics. Discharge antibiotics, unsurprisingly, the most commonly prescribed antibiotic was cephalexin or Keflex at 42%, with Septinir being the second most common cephalosporin prescribed at 35.5%, and then a much lower number with cefuroxime, cefodoxime, ceftriaxone. In the fluoroquinolones and Bactrim group, Bactrim was the most prescribed at 47%, followed by ciprofloxacin and levofloxacin at 39 and 13%. The length of therapy, the mean length of therapy, was 7 to 9 days between both of these groups, with cephalexin being roughly 8 days and then 9 days for Septinir, and then our most prescribed for the fluoroquinolone and Bactrim group, with 9 days for Bactrim and 7 days for both our fluoroquinolones. They were able to provide some supplemental data as well here, and this is a table going over the different dosing regimens used from this study. And you can see here there is a vast amount of different dosing strategies used in this study. Something to note here. It's great to help identify that these certain antibiotics, but not necessarily providing any insight on specific dosing regimens. In terms of pathogens identified in these patients that did have urine cultures collected, unsurprisingly, E. coli was the most common at around 40% for both groups, followed by Klebsiella pneumoniae at a much lower rate of 2%, and then Staphylococcus at 2.2%, Proteus species 1.4%, and going down the line there at less than 1% for the remaining groups. But common for trends that E. coli is our most common pathogen in these patients. Looking at the results for our primary outcome. So again, they were looking at a composite outcome of treatment failure at 14 days, and they did not find a statistically significant difference between these groups. A little bit lower numerically, the cephalosporin group did reach this composite outcome 17.2% as compared to the fluoroquinolones and Bactrim at 22.5%. Digging down a little further into the reasons why the composite primary outcome was reached. So the most common reason for failure would be representing to the emergency department or urgent care for urinary symptoms. New antibiotics for UTI were the reason for 9.7% of cephalosporins, 13.7% for fluoroquinolones and Bactrim. Reoccurrence of symptoms was the next most common reason for failure, 9.4% again for cephalosporins and 11.8% for the fluoroquinolones and Bactrim. None of these reached any statistical significance, and most of these are roughly the same between groups. In terms for reasons of new antibiotics reported, I thought this was interesting given the difference in resistance and susceptibilities amongst these geographical locations. Only 4.5% of the cephalosporin group noted resistance on susceptibilities and 7.4% amongst the fluoroquinolone and Bactrim group. They did find that overall susceptibilities to empiric antibiotics were, again, not statistically different, but a little bit numerically higher in the cephalosporin group, with 81% being susceptible to the empiric first choice of the cephalosporin and 76.1% for the fluoroquinolones in Bactrim. Here they also broke down by study site as well. They did not include treatment failure for Bactrim, but they did include for cephalosporins and fluoroquinolones. And you can see here that the percent of failures between these two different treatment groups vary pretty frequently depending on what site you're at, with some sites having greater treatment failure for the cephalosporin groups and other sites having greater treatment failure for the fluoroquinolones. Secondary outcomes. So again, they were able to do some subgroup analyses, breaking down specifically first, second generation cephalosporins and comparing them to third generation. And then again, our guideline first line recommended agents, fluoroquinolones and Bactrim. None of these comparisons reached any statistical significance, although I do find it interesting that the numerically first and second generation cephalosporins, around 17% of patients reaching that treatment failure composite, as compared to a close 17.4% in the third generation cephalosporins, 22.5% of the fluoroquinolones in Bactrim. Looking again at did empiric therapy, is it appropriate based on urine culture susceptibilities? And as stated earlier, around 80% for the cephalosporins and 76% for the fluoroquinolones and Bactrim. But the takeaway from here, right, is that even breaking it down between second gen, first gen, and third gen cephalosporins, the rates of treatment failure and appropriate susceptibilities for empiric treatment were roughly the same. So some strengths for the study. It was multi-center. I thought the inclusion criteria very applicable and generalizable. They were able to include complicated pyelonephritis patients and did do a subgroup of those patients as well, and found no differences between if you controlled for complicated pyelonephritis or not, and also giving a good definition of breaking down males and those who had pre-existing anatomical conditions, as there is not a lot of evidence out there currently for complicated pyelonephritis patients. I also thought it was a strength of the study, again, having clear definitions for, again, pyelonephritis, complicated, uncomplicated, and also what constituted as positive urine culture, and excluding a lot of common contaminants that would otherwise get treated as a real pathogen. Outcomes are applicable to real practice, and the breakdown by cephalosporin generation just provides more data for some of those cephalosporins that, again, there's been some controversy around whether or not the kinetics, the in vitro data affects what the clinical outcomes might be, specifically thinking about cefodoxime, ceftonir. Some limitations of this study. It is retrospective in nature. UTIs in general are associated with high rates of diagnostic error. They did also use only 2 ICD codes to identify patients. Patients may have received care at different facilities outside of these study sites. Using cefazolin as a surrogate marker for all cephalosporins, this could underreport the true resistance to cephalexin, but might overreport resistance to third-generation cephalosporins, such as ceftonir or cepidoxime even. The majority of sites were only on the eastern side of the United States. And again, a takeaway, right, is that depending on your antibiogram and your resistance patterns, it may not be quite as applicable to those that might practice in a different region of the United States or internationally. There was a higher rate of IV antibiotic administration in the cephalosporin group, which does go along with the IDSA guideline recommendations, but a potential clinical co-founder there. Great variability amongst the dosing regimens prescribed, and the majority of patients in this study were female and did have uncomplicated pyelonephritis. Some conclusions and key takeaways from the study is that the empiric treatment of pyelonephritis with cephalosporins did not increase treatment failure rates as compared to IDSA recommended first-line therapies. And with the increasing rates of E. coli resistances, this was, again, the most common pathogen found in the study. And they did find increased resistance to fluoroquinolones and Bactrim. This does make treatment with cephalosporins an appropriate alternative and provides more evidence to back the rationale for its use. And it does provide some additional evidence, although only around 20% of these patients did have complicated pyelonephritis. There are not a lot of current data out evaluating cephalosporins in this patient population. So this helps add to that discussion there. All right, here are my references. Any questions?
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.